invite on stage a next speaker. He is a graduate of King Edward Medical University. He went on to complete dual fellowships in internal medicine and rheumatology. He was awarded a PhD from the University of Dublin, and he has helped establish the National Psoriatic Arthritis Registry of Ireland.
He has recently returned to Pakistan with a passion to provide state-of-the-art care for rheumatic disorders and has successfully managed to establish the Rheumatic Diseases Registry of Pakistan. Kindly welcome Dr. Mohammad Haroon onto the stage.
So we're going to start. I'm going to talk about non-infectious uveitis. I know the topic assigned was more about the generally talking about non-infectious diseases, but there were so many and the time was 15-20 minutes. So I'm going to focus more the more common one that we see and a lot that we can do about these patients. So I'm going to focus on non-infectious uveitis. Apologies. So let's start with a couple of our patients. So this is the typical one, and this is, I'm sure all of you guys must have seen a few of those ones. So this was a patient that I saw, I think was in 18 and 19 when I came. So this was a very refractory case of 5 years old, 5 years out of the history of uveitis. He had very severe uveitis, already significant damage made to both of his eyes. He had already got the vitrectomy done, as you can see. He was significant visual loss. And you can look at all the usual, the things that we use, steroids, azathioprine, cyclosporin. He was already dependent on quite a high dose of steroids, 20 to 30 milligrams of steroid that he was already using. And of course, still he was keep on getting some now and then flares. He was getting quite regularly periocular injections as well. And again, after every, so I don't know, about 4 or 5 months, 6 months, he would get one injection and still he was in trouble. So again, not surprisingly, this is a young chap, 17 years old. He was already missing his college and poor bone health and all this. And seriously, this was the frustration that you can smell. So I started the usual one that we used to do in Ireland, adalimumab. It was difficult to source, but it was easily available. I was surprised to find adalimumab we started, and it was absolutely dramatic recovery. Adalimumab was, of course, combined with methotrexate, and literally within 6 months, he was absolutely off steroids, and he's absolutely living a normal life. So this was one of the success stories that I wanted to share as a start. And there is a few of the themes that, of course, this was the refractory case, of course, responded very well to the standard treatment. And this is the who should be referred to rheumatologist. So this is another patient, 29-year-old male. He had 4 episodes of anterior uveitis over 3 years. He does have some low back pain, but again, it was quite non-specific low back pain, not the usual inflammatory back pain criteria that he would fulfill, but he was still having some non-specific back pain. So quite the usual one, acute anterior uveitis, HLA-B27 positive one, the mild anterior uveitis. So he was also having the same. Topical steroids were sorting him out. So again, because he was having these frequent attacks and the back pain was there as well, so he was looking at the DUET algorithm one. He literally fulfilled the criteria that he should be referred to a rheumatologist and should be investigated further with MRI and so on. So on those basis, he was diagnosed with ankylosing spondylitis, spondyloarthritis. So how do we know the arthropathies, for example, if you look at reactive arthritis, this particular case is a reactive arthritis related uveitis. So this is just, I want to highlight that these patients can have a very florid onset, not the usual AS or the psoriatic one that usually present with the uveitis. The reactive one, they present very florid uveitis. For example, this lady. So this is reactive arthritis, literally 4 days history of these symptoms, and literally within 1 day, she was from the right eye blind, almost blind. With the hand movements was barely she was able to count. Within, as I said, within 1 day. So that's the story with her. Hand movements, and there was a lot of anterior uveitis. There was a dense vitritis. So he ended up that we need to give her quite high dose of intravenous steroids to tackle. But again, it was a reactive arthritis. I just want to highlight, do not just ignore these cases because they can be very florid and the permanent eye damage happens literally within a couple of weeks, if not more. Frequent attacks of anterior uveitis, so we know the HLA-B27, the usual one with the spondyloarthritis they present. So this girl, 18 years old girl, strong family history of spondyloarthritis, kept on getting the recurrent attacks of anterior uveitis, investigated as regards there might be background of SPA, but the MRIs and everything was fine. She, although didn't have the back pain, but it did get her MRI done. MRI was normal. Again, because of the recurrent anterior uveitis, so she was started on methotrexate just so that we can reduce down the topical steroids, because the topical steroids on its own can cause significant, of course, intraocular pressure and the cataracts. So not just think about that some patient is responding to the topical steroids, so they also carry quite a significant long-term side effects. So this patient was started on methotrexate purely on the basis of, although they were short-lived, but she kept on having those long-term topical steroids. So of course the rheumatologist, I'm sure we all know that the majority of these patients with a non-infectious uveitis would have some form of systemic autoimmune disease as the underlying case. And the important thing for us to remember is that they need immunosuppression. And believe me, the ophthalmologists, absolutely they run away when you talk about methotrexate and forget about the biologics. So that's why we need to give them a bit of help to find out. So we know about anterior, intermediate, and posterior uveitis. I'm not going to waste a lot of time there. So the most common is anterior uveitis for our junior colleagues. So anterior uveitis, of course, because the anterior chamber, so the symptoms can be very, very helpful. Simple. So as I said, the photophobia there, the blurring of the vision, there would be sort of the usual, when they talk about, ask the patient a couple of things. I ask for all of these patients when they go out in the sun, when there's, for example, in front of their screens and all this. So there can be quite sensitivity to the light. When there is a vitritis there, of course, there is some element there of the photophobia as well, along with the blurring of the vision. But when you talk of the posterior uveitis, of course, there won't be any symptoms there. You're talking about a patient who has got just the blurred vision with no pain even a lot of times, just the blurring of the vision. So that's why we need to be aware what symptoms or what part of the uveal tract is affected. So we know that there are a lot of infections and neoplastic causes exist, but it is believed that more than 50% of these patients would have some form of underlying systemic immune-related disease. So this is a fairly comprehensive list of immune or the uveitis related, where there is uveitis exists with arthritis, apart from only 3. So these are the 3 diseases in the bold one. So these are the only diseases where you get the eye involvement only, but no arthritis. But the rest, there will be some form of arthritis along with uveitis. So it's not just SPA alone. There are a lot of other arthritis and autoimmune diseases as well. So if you look at, for example, people say the uveitis is not that common. Look at the prevalence, for example. And this has internationally been more or less replicated. The similar studies is that around 100 to 150 prevalence per 100,000. So you can imagine 1 lakh patient population में more than 100 cases of uveitis. That's the prevalence. And if you look at the incidence, 52 cases. Again, every year there are going to be new cases. So if you look at what could be the characteristics of uveitis patients, again, not the head-to-head trials, but just looking at the Middle East versus the Europe ones, the only difference, again, not surprising, in Europe, of course, the idiopathic uveitis is more common, but when you look at the Middle East one, there is a Behçet's disease-related uveitis. It is the most common form of systemic autoimmune disease behind this uveitis. Not to forget about the impact of uveitis. We all talk about of course, the diabetes and all this, but if you look at the impact of this uveitis, it almost mirrors the impact that you get with the uveitis. Not only this, but it is the leading third cause of blindness when you talk of the developed countries. Developed countries, third leading cause of death for adults. And the most worrying is that every second to third patient is a working man or woman, of course. So these are the working population, adults who are getting blind because of this particular disease. I skipped that one. So this is the important one. So just even one episode of uveitis, people talk about, oh, this is not the recurrent one, this is once alone. So they are talking about the longitudinally following up the patient. This is, first of all, what you're looking at is the survival curve with the hazard ratios. Hazard ratios from this, very important to understand, is the adjusted with the COGS regression analysis. So what you're looking at is the hazard ratio of 5.2 after getting one episode that they get this. Or in other words, let me make it simple. After one episode of uveitis, any person in the long term would be 5 times more likely to have intraocular complications. But when you look at the patients who are going to be having persistent persistent uveitis means that the uveitis lasts more than 3 months. So that's usually, most of the patients would land to us who would have persistent uveitis. Then this hazard ratio is 8.9, means 9 times more common, more likely to have significant intraocular complication. And what are those complications? These are the usual ones, the cataracts, the visual, the retinal detachment, the blindness, and so on. So do not ignore just about the other ones. The intraocular complications are significant, and you can see the figures, the 58% of the patients would have some intraocular long-term complications even after one attack of uveitis. And of course, we know about this, the cost, the direct and indirect costs are more than 2 times compared to. So why it's important that we collaborate, why it's important that we meet our ophthalmology colleagues and highlight them about these patients, because believe me, if you talk to them, there are a significant number of patients who are just with them and they keep on getting the steroids. Right. So we need to inform our, of course, ophthalmologists that we do sort of give a lot of weightage to uveitis because we have included this in our SP algorithms. And uveitis is the most common extraarticular manifestation. Around 40 to 50% of the patients with spondyloarthritis would develop uveitis. Of course, that increases the longevity of this. And again, that also depends on what particular subtype of of spondyloarthritis we're talking about. That depends on the background of HLA-B27 prevalence. For example, of course, IBD and AS and so on, there is a high prevalence of HLA-B27, so there is more common uveitis in those subsets of spondyloarthritis. Again, I talk to my ophthalmology colleagues about these 2 studies quite often. And what we are seeing here is that the more than 50% of the patients with uveitis, when they present to uveitis, more than 50% would have undiagnosed spondyloarthritis. That they will not know that they have spondyloarthritis because they would have back pain, they would have some joint pains, but of course they don't get much bother, or they might not go to a doctor unless they get the severe form of eye-threatening disease. Right. And when we talk about the uveitis patient develops, for example, the IBP or the spondyloarthritis patient when they develop uveitis, so this is even worse. So what you're looking at is the short form 36, or the quality of life, the mental health and the social health and the usual social relationships. They are far worse in spondyloarthritis patients who have uveitis compared to spondyloarthritis patients who do not have uveitis. Not only this, we have longitudinal data as well on these patients with the uveitis. For example, this is a desired cohort. So what you're looking at is that they have a significant worse BAS-DI score. They have significantly worse BAS-P score. Not only this, but they also from this, the OASIS study has clearly shown the patient with the spondyloarthritis who does have uveitis, they have a worse radiological scores. So SPA patient with uveitis does far worse compared to another SPA patient who doesn't have uveitis. So we are not talking about patients who are just having asymptomatic disease. We are not talking about the patients who are just sitting at home doing nothing. Our cohort has shown, and again, number of afterwards have 2 other studies have shown the same, that when you talk of these asymptomatic disease are not the asymptomatics, are undiagnosed spondyloarthritis. These are not the patients who are sitting at home. They are unfortunately knocking onto the doors of different disciplines. For example, GPs, physiotherapists, more than 60 to 70% of them, they have already been to other disciplines. But unfortunately, this particular link doesn't get recognized that they could be having some underlying spondyloarthritis. I'm sure you might have heard me talking about this. So let's talk of therapeutic options. So we know about the steroids. Steroids, of course, the mainstay treatment. We know from the NF that it affects the NF-kappa B. And a couple of things that we use, we know about the topicals, of course, that is the usual standard treatment. Then there are periocular, and then the usually oral one is usually end up treating. And again, it depends on the severity of underlying. And the important thing is, because when the patients comes to us, that we need to look at their files, because you know the language that the ophthalmologists use is very difficult to understand. And of course, what I do is I always get my ophthalmologist to have a look at and ask them clearly what you're looking at. So it's very important that I always ask them if they can try periocular steroid injection. They are extremely helpful and does give you good relief for 2 to 3 months, or even in some cases quite significantly more. In last couple of years, there has been these implants that have been placed. In Europe, at least, they do it quite often. We don't have it here, unfortunately. There is a quite quite a good data if you look at, for example, these implants can stay and can be effective even up to 2 to 3 years. 2 to 3 years. That again, that's there, for example, a couple of studies, again, not the phase 2, phase 3, some studies have shown, but if you look at the latest, for example, the Cochrane database, for example, of the systematic reviews, they think that probably doesn't do much, but again, at least there is some data at least that they can provide some long-term relief if you leave the implants in the vitreous. Looking at our usual standard treatments, for example, the methotrexate and mycophenolate, they are, of course, one of the best ones. This is the only head-to-head study, methotrexate versus mycophenolate, after small enough numbers. For me, that's a positive trial, but again, if you can see the P value of 0.09, so there was already bordering to significance. If the numbers could have been higher, you could have seen the results. But in this particular subgroup analysis, methotrexate for the first period, then methotrexate when you talk about posterior uveitis or pan-uveitis. So that's why, to my eyes, methotrexate is a little bit superior to mycophenolate when you talk about uveitis. Again, not the direct comparison, but the data extrapolated from the different studies. So what you're looking at is that the mycophenolate and methotrexate, they does provide good relief that the patient's steroids could be reduced down way below less than 10 milligram. So they do work. We know about the visual one, the adalimumab trial. These are the patients with active uveitis. Hazard ratio, as you can see, I don't need to mention one, is 0.5. That is significantly superior as towards adalimumab versus placebo. This is visual 2. These were the patients who were having inactive disease, but they were dependent on oral steroids. Again, the hazard ratio is 0.57, significantly favoring adalimumab compared to, of course, the placebo. And these were the bases that why adalimumab is formally licensed. Infliximab, again, because, of course, there is no major company backing it up to go for randomized controlled trials. But this particular study, for example, retrospective study again, but you can see the 75% of the patients within around 44 weeks, they were able to achieve some good remission from uveitis. This is, again, multinational study, multi-center study, not placebo-controlled or randomized controlled trial, but they looked at both infliximab versus adalimumab, around 100 patients with the infliximab, and there were adalimumab around 60 thereabouts. And what they found out was that the both drugs were quite comparable as regards the reduction of uveitis. So to my eyes, they both work well. So I think we all know that we try, of course, the usual, the topical, if that helps. Again, for my eyes, if the topical steroid requirements increases or persist, then we should be going on second-line agent. Methotrexate first, then try cyclophosphamide, then comes cyclosporin versus azathioprine. If that is still not working, then shouldn't delay at all and going on biologics. Anti-TNF is the usual standard treatment. As I mentioned, again, talking about the tocilizumab, there have been number of studies, but very small studies, 5 patients, 10 patients, not major. This was the only phase 2 study, formally conducted study, which was a negative study, and afterwards, of course, no phase 3 trials were conducted afterwards. There have been few afterwards, as I said, this only one was the last one, sorry. This was published in Seminars in Arthritis and Rheumatism only a few weeks ago regarding 49 cases that they have with the Behçet's disease-associated uveitis. And they looked at adalimumab and infliximab versus tocilizumab, and they all three did more or less the same, apart from tocilizumab did a little bit better when they were the patients who had anti-TNF failure. So if anti-TNF failure patient, probably tocilizumab might have some relevance. JAK inhibitors, of course, now we try JAK on literally everything, wherever we can get our hands on. There is only baricitinib, that's the ongoing phase 3 trial. We need to wait for the results. This was the filgotinib, which is JAK1 inhibitor, is not available anymore. Phase 2 trials were stopped. Phase 3 trials were stopped because there was issues about the testicular toxicity. But this was the trial, phase 2 trial, which was a positive trial. But unfortunately, because of the testicle issues, this was stopped, phase 3 trials. Again, it's very, very small sort of, but no convincing, to be honest, the JAK inhibitors. I have tried, but I'm not sure whether I got the results what I wanted. But these were the patients who couldn't afford the anti-TNF. So that's why the start off was, of course, the anti-TNF. After switching them to JAK inhibitors, again, that wasn't the best start. So when to treat? So we really need to be telling our ophthalmologists, of course, too early and too late, it doesn't take long. It doesn't take long when we miss the boat. And these therapies, these all immunomodulated drugs, they work, and there's absolutely data to prove this, that within last at least 1 decade, the uveitis, the usual blindness and all those deadly outcomes, the choroidoretinitis and all these, there have been serious reduction in those ones. If anybody has interest in reading and more about this, so this was a very good document, very comprehensive document. And I represented Ireland when I was there, published in 2017. So different European countries, so there was a collaboration looking at what can we do in terms of the uveitis, that we can formulate some plans, some sort of which are the patients who should be targeting. So to conclude, uveitis is not that uncommon, and of course the complications are common, but they're preventable. They're preventable. So the sooner the systemic treatments are started, the better the outcomes. And of course, don't leave your ophthalmologist alone, because they have no clue about when you talk of immunotherapies.
Thank you, Dr. Haroon.